and gentlemen, euthanasia is an extremely sensitive issue in India. But there have been hugely important judgments of Supreme Court on passive euthanasia. What really is passive euthanasia? That's something that we are going to be looking at very closely tonight. But in terms of passive euthanasia, before we get on to what the Supreme Court guidelines have been, the Government of India has now released draft guidelines on withdrawing or withholding medical treatment in terminally ill patients, also known as passive euthanasia, allowing for withdrawal of supportive care like ventilation, dialysis or ECMO when a patient has been declared brain dead and are unlikely to benefit from advanced intervention. The conditions, according to the Government of India, include patient has to be declared brainstem dead, medical prognosis stating patient is unlikely to benefit from aggressive medical interventions with the patient in advanced stages, foregoing life support proposals made by a panel of at least 3 doctors, informed refusal from the patients or the surrogates, and considerations of patients' best interest. The draft guidelines have been received with mixed reactions, as I said, by the medical fraternity. Such decisions are traditionally made by doctors based on good faith, and the job is to inform patients or the family about the condition, and that the doctor's job is to explain to them just about that, about the diagnosis, about the prognosis, and after that, it is their call whether they want to continue their life support or not. This is what IMA President R.V. Ashokan has said, who has also stated that with these guidelines, it's now the onus on the doctors. The guidelines intend to create a framework defining role of doctors, and this is concerning for us, is what the IMA president has said. On the other hand, there are others who are welcoming this decision, like Dr. Sushma. She was part of those who also gave their recommendations for the draft guidelines, and she goes on to say that no one has taught us what our approach should be when the end is inevitable. She's talking about doctors. And that as doctors, we keep treating even if we know that there is no chance of recovery. This policy can help in better understanding of diagnosis and the prognosis. Patients, family members will be able to make informed choices. That's what Dr. Sushma Bhatnagar has had to say. The Supreme Court legalized passive euthanasia in 2018 and had held the right to die with dignity as part of the fundamental right to life under Article 21 of the Constitution. In 2018, the court had said that dignity in death is as much a part of right to life under Article 21. To deprive an individual of dignity towards the end of life is to deprive the individual of a meaningful existence. And if you remember the 2011 Aruna Shanbag case, a Mumbai nurse who was assaulted in 1973, she was left in a persistent vegetative state. In fact, she lived in that vegetative state for almost 42 years. It was a journalist, Pinky Virani, who filed a petition for euthanasia on her behalf, and the hospital authorities, the staff, they wanted to continue the care for the nurse. It was in May 18, 2015 that Aruna Shanbag died at 66 out of pneumonia. It was during the Aruna Shanbag case that the Supreme Court stated in 2011 passive euthanasia can be allowed under exceptional circumstances. Right to life under Article 21 does not include right to die, but right to die with dignity is a valid aspect of this right. In discussion tonight, we are looking at passive euthanasia, which is, by the way, different from euthanasia by itself. Internationally, Netherlands, Belgium, Luxembourg allow both euthanasia and assisted death by suicide, and it applies to those experiencing unbearable suffering. In Switzerland, there have been permissions for assisted dying but not euthanasia. In Canada, The euthanasia law has recently been expanded to include mentally ill patients, but the final decision on that is yet to be awaited. United States, some states allow for euthanasia while others do not. This is largely the global picture, but remember, more countries than not walk this path. More countries are exception to this than they are not, in the sense that many do not walk this line. There's a large debate around all of this. I'm being joined at this point by a panel. Dr. J.A. Jailal will join us shortly. He's the former national president for IMA. Dr. Ratish Sareen, the author for India Decides on Euthanasia. Is the debate over? He joins us. Dr. Rahul Pandit, the chair for Intensive Care Unit at Sir H.N. Reliance Foundation Hospital, joins us. Dr. Sanjeev Bagai, chairperson for Nephron, joins us, as well as Dr. Dhwani Mehta, co-founder, Vidhi Center for Legal Policy, also joins us. Thank you very much, all of you. Very good evening. Thank you for joining us. Let me just first take the question at this point to you, Dr. Rahul Pandit. How do you look at this entire debate? How do you look at what the government has proposed at this point? You're somebody who's taken care of umpteen patients at the intensive care unit. IMA has gone ahead and opposed or objected to this draft bill, but how do you look at this?
Good evening, and thank you for having me on the debate today. So there are three aspects of this. One is what you talked about, euthanasia. I think that's completely separate. Let's not confuse people about euthanasia at all. The second is withdrawal of life-sustaining therapy for people who are terminally ill, or secondary, you could also say for futility, where there's absolutely no chance of having a life going on despite all the life-sustaining therapies going on in intensive care. I think this current law, which the Supreme Court, the current decision which the Supreme Court gave, and the government, which is basically bringing out a draft guidelines, are a welcome change for people who might be going through this kind of a process where they have no meaningful life, or there is absolutely no chance of them coming out, and they're still stuck on a ventilator or have been going on a dialysis or ECMO or so on and so forth. Now, the problem is not about accepting that. We all have known, and we have all, as doctors, been informing the patients and the next of kin that there is absolutely no chance of having a meaningful outcome from this, and the death is inevitable. However, there has been no process actually to think about that, can we limit care or can we actually give them death per dignity? All of us are going to die one day, and if the death is imminent, if the death is inevitable, nobody wants to die stuck on machines and be prolonged with the agony and suffering. And that is where this process sort of brings into the whole picture a stepwise approach of how it can be done legally. And the Supreme Court has actually gone through a lot of debate and discussion before coming out with this pathway. The Indian Society of Critical Care Medicine, and I am a member of the IICCM, I'm a past vice president of IICCM, was one of the co-petitioners, and Dhwaniji was actually one of the lawyers who represented us into the court, who have basically gone through each and every aspect of this. And we see patients all the time who are sort of brought into the hospital. Say, let's take, for example, a terminally ill cancer patient who comes to the emergency department. The first role of a doctor in the ER is to do everything to try and save the life, which means put them on a ventilator, start blood pressure medicine, supporting medicine, and then bring them to the ICU. In the light of time, over the next day or two, it becomes very clear that there is absolutely no chance that this person would recover. And then this person is on a ventilator, this person is on life-sustaining therapy, and there is absolutely no chance as of now, until now, that we could have actually thought of even stopping the therapy. So we continue until the life goes on. At some stage, the heart stops, and despite resuscitative measures, the patient could not be resuscitated, and that's when we declare a patient dead. Now, at least we have an avenue to talk to the family, to explain them that there is no hope of a patient coming out of this problem. Let us see if the family agrees, and if the family agrees, you put up a primary medical panel. The primary medical panel has to have a consensus decision that this is a futile process where there would be absolutely no chance of the person coming out of this illness. The family has to agree to that, and then a secondary panel has to be constituted as per the Supreme Court decision. Once both the panels agree to it, only then the process of withdrawal can happen. So there is enough safeguard for doctors, for families, for everybody, and there is enough time given for all of this to be thought of. And at every time, there has to be a complete consensus between the doctors and the family members. It cannot be a unanimous decision by any one person or any one part of the two parties, which is the family as well as the doctors in the hospital. So it's a unanimous thing. I think this process would definitely help in having a dignity of during the dying process, and would restore some amount of confidence in people who are terminally ill, that they may not be actually put onto a machine with absolutely no future out there, and perhaps the next of the kin could be able to make a decision about this.
Right. Important perspective, important points, important facts being put in place. Dr. J.A. Jailal also joins us right now, former National President for IMA. Thank you very much for joining us. My question straight to you, what are the big concerns? Why are you all objecting? Why is the IMA president objecting to the draft guidelines which is out by the government? What is it that you all are not welcoming in it?
Yeah, first of all, even the perception of saying that there's unnecessary equipment, unnecessary hospitalization, and prolongation of the life is being carried out, and this is a wrong perception. What we have seen in COVID time, thousands of people were longing that they couldn't get a ventilator. So ventilator is not one thing which is going to be an unnecessary one, or what is not to just to put for the prolonging the patient. Second, we always believe there is something more than a law, ethics, than a patient-doctor relationship. No doctor in an ICU will be put on the patient continuously on that. And we have every day morning, we talk with the patient, explain the situation. It is up to the patient to decide. Certain times the patient themselves, their relatives lost. The son is in UK, he has to come. Please put the patient on there. Though we know for sure that the patient may not be able to survive. But that is on the contrary. There are situations where the patient attendants come and shout at the doctors, why you are putting on the ventilator? We don't have a money, please take away. So this is a very dilemma, ethical situation. What our concern is, don't bring law into that. When you are bringing a law into that, how many hospitals, how many people in the country can get a typical ICU care, what we are talking about, Apollo care or AIMS care? India is a rural area. You cannot have every area, every rural setup, every medical college has an ICU setup where we can have 4 doctors coming in a primary level, 4 doctors coming in a secondary level to take a decision. But this shall be a decision which is taken by, in a good faith, good relationship with the doctor and the patient after due consultation and due thing. So our concern is, there are so many things for the law need to become. The safety of the doctors, safety of the things. When we are talking about that, you say that the health is a subject belonging to the state. We cannot bring a law to protect the doctors. But now the same government is trying to bring a law to say that, no, we will be bringing a law to protect everybody. And absolutely, it is going to cause a chaos. More and more doctors are going to spend time in the court, and we are more worried about writing the legal things. When the patients, even the people who are coming in the need and emergency and actual need, and there will be a lot of hiccups in putting the patients on a ventilator when they are coming in their need also.
So, Dr. Jailal, help me understand this. You are essentially saying you are not against passive euthanasia. Is that what you're saying?
Absolutely, we are not
as a medical practitioner, you are not against passive euthanasia. You are against the way the panel says there has to be a 2-level panel of doctors along with the family, and it cannot be a unilateral decision from either cases. Is that what you're saying? That's what you're concerned, that doctors have to take a decision in this particular case?
Our concern is, this should not be decided by the law. This should not be decided by something in an external agency. Each patient situation, each patient atmosphere on the site, it is a different. So it has to be a decision taken in good faith by the doctor treating patient and their relatives. It should not be the law which is going to come. Then please take it away from the doctors and bring it to the court. Let the court decide on this.
Dr. Rahul Pandit, I have other panelists who have to make their first remark as well. But before I go to them, very quickly, do you want to respond to the concerns that Dr. Jailal has made at this point?
I think Dr. Jailal has brought out a very important point about the rural applicability of it across the country, especially the rural areas. And I also understand where he's coming from in terms of where can the doctor panel be formed to actually have 3 doctors come into small nursing homes, small hospitals in rural area. It is going to be a ground level challenge. So I think implementation of the judgment will take some time. But I'm not looking at how, see, as a clinician, as an intensive care specialist who looks after terminally ill patients, critically ill patients, patients who require emergency care all the time, I see this as something which everybody has thought that if death is imminent, then we should be basically having a dignity in the dying process. That's what I look at it. I am not necessarily saying that it will be immediately implemented. Absolutely not. I completely hear what Dr. Jailal is saying.
Okay, Dr. Ratish Sareen, if I can come to you, and I'm coming to you also because you've written some very important publications. One of them is India Decides on Euthanasia is the debate over. It's a very sensitive, it's a very emotive topic. We are, of course, not talking about euthanasia today. We're talking about passive euthanasia. But do you think India is at the stage where India is willing or ready to accept something like this?
Yeah, the article which I have written was around 5 years back when we have the landmark judgment from Supreme Court, the Aruna Shah case. And thereafter, that was a landmark judgment because that was the first time that the apex court gave a judgment where they have actually legalized passive euthanasia. And we have to differentiate between active euthanasia, which is quite prevalent in developed countries like Netherlands and Belgium. However, Indian scenario is entirely different. We have a
But
huge
not all
population and
developed
there is a
countries. We also
rampant.
have to say that they are not a widely
Yeah,
implemented practice. Even in developed
yes.
countries, you have a
Even,
lot of divisions in
yeah,
their
there are
opinions
only
over
few
it. So, but
countries
please
who
go ahead.
practice euthanasia. Now, when you talk about India and this judgment that came up from the Supreme Court, the nutshell was the Supreme Court recognized passive euthanasia. There was a thing that came up was the advanced medical directives. Now, that was also known as the living will. Well, like now I can make a living will that whenever I have a severe illness or there is something that you need to put me on the ventilator, I can make a will, get the will registered. Now, at that time, the procedure of the living will was a very, it was an impossible procedure. The procedure was it was so difficult to the extent that even after 3 years, there was not a single person who has done a living will. So, in 2021, the procedure was simplified. Now, when we talk about law, the Article 21 that talks about the positive right, the right to live, similarly, there is the right to die with dignity. And this has been a need of the hour because there have been families, we are moving towards nuclear families. We face a lot of situations where there are patients who are, terminally ill and they are on ventilator for say 15 days, 20 days, apart from the financial constraints, there are cases where there is no hope of recovery. And if you look at the draft guidelines which has just come up, because they're available on the Ministry of the Health and Family Welfare, and they've invited comments till I think 22nd of October, where they have firstly mentioned there are certain 4 conditions, and the first condition is they mention it very clearly, it's a brain dead patient. So when it's a brain dead
That's
patient,
right. We've gone
as
through
of
it. That's
now,
right.
so we are talking about a brain dead patient, withdrawal of life support from a brain dead patient. That is the first condition which has been mentioned in this draft guideline. So I think this is slightly, it is not exactly the passive
Right.
euthanasia which was there in the Supreme Court judgment. This is more on in line towards the organ transplantation also, because in such a cases where the brain death has already taken place, literally there is no point in keeping the patient on the ventilator. You need counseling to the family members. We need to make them understand that this is the right time. They can donate the organs of the deceased, and then we can actually give life to more people. So I think it is a welcome response. It's a
Right.
progressive
Okay.
thing, and it should be taken in the correct light. Although there is a lot
Okay.
more to it, we need to have a very
Okay.
strong documentation at the part of the hospital. The counseling process has to be very strong because we have a diversified country. We have a different literacy level. There is village people who are coming to the metros and the big hospitals getting treatment, and then we have to make them understand that what it is all about. So the
right.
hospitals have to be very, very cautious in practicing
Okay.
this.
Right. I get your point, and we hear you as well. Dr. Dhwani Mehta, if I can get you in. Dr. Dhwani Mehta, you've been part of petitions before the court that have argued for passive euthanasia, who have demanded for dignity in death, as you have put it across. But let me ask you this question. From when you have started presenting these cases before the court to where it is today, where do you look at India? Because there have been cases like in Aruna Shanbok's case, which is often used for references in for verdicts such as this. But then you also have the other part of India that says, who gets to decide when to pull the plug? Why should anybody decide that? And then you have the other side of the debate, which is what the court has said about right to dignity in death and in life, and the huge amount of expenses that one has to go. But I want to understand, what was your motivation? What led you to the court repeatedly?
To protect this fundamental right to die with dignity. And let me just clarify that it's not passive euthanasia that we're talking about. The appropriate term here should be withholding and withdrawal of life support. The use of euthanasia, even when you call it passive euthanasia, causes the kind of confusion that we are seeing today in this debate. So the idea was to present the right information before the court and to actualize this right to die with dignity, even for patients who don't have decision-making capacity. So today, if I am in an ICU and I am perfectly conscious, I can refuse to be put on a ventilator, and the treating team must respect my decision. We went to court and intervened in this matter along with Common Cause to argue that even when a patient doesn't have that decision-making capacity and medical treatment is not likely to be beneficial, the treating team should still be able to withhold or withdraw life support, because that's an essential component of dying with dignity. So and honestly, the debate here is a little misplaced, because the court, I fully understand what Dr. Jailal is saying about the law not having a role in this. Ideally, no. In countries the world over, this kind of withholding and withdrawal of life support is not governed by the law. It's governed by professional medical guidelines. There is no intervention of, the statute or courts in this. But the way in which the law has developed in our country is that the court has intervened. The court has laid down a judgment. We are now, like it or not, bound by what this constitution bench of the Supreme Court has said. So all that these
Dr. Dhwani Mehta, while you make that point, I also want to come in and say, even when Supreme Court gave that 2018 verdict, the Supreme Court said that we are taking this up and we are saying this, but this is a case of legislation and you can't pass the buck.
Yeah, it says that we are laying down guidelines until Parliament or a state legislature decides to replace this with legislation. But what the court already also did was lay down a very detailed set of guidelines, which unfortunately none of them can be implemented unless state governments pass orders to actually actualize them. So, for example, one of the steps requires the setting up of a board which has a nominee of the chief medical officer. Now, who will do that? It is the state government's duty to direct their CMOs to nominate these kinds of persons. So these draft guidelines that the ministry has issued, again, it's not about the union encroaching on a subject of state legislative competence. They're only guidelines which, and if you will see, there's an annexure to the guidelines which contain model draft orders for states to adopt. So it's entirely up to states to develop their own procedure in accordance with the Supreme Court's template. These guidelines are only to actually implement and operationalize what the court has already said. So it's not as if they are saying anything new. And therefore, the objections that are being expressed, you might as well be expressing your objections to a 5-judge bench of the Supreme Court, because the law on this has already been laid down.
Right. Dr. Bagai, before I come, very quickly, Dr. Jailal, do you want to respond to Dr. Dhwani? I have to go to Dr. Bagai for his comments. But Dr. Jailal, do you want to respond?
This, we are now calling it as only a passive euthanasia. And withholding is a different terminology. It is not when nobody is putting it unnecessarily. When you are putting something
but that
unnecessarily.
Is what the court has said, withholding or withdrawing. The
And
IMA has called this passive euthanasia, but the court has very clearly said about withholding and
then what
withdrawing,
is
which the draft
what is
guideline also
passive
speaks,
euthanasia?
isn't it?
Can you define then passive euthanasia?
So it's
It
not
is,
a
it
term
is
that should be used. There's a
Dr.
2018
Bagai.
document
no, no.
of
Second,
the
second
Indian
Yeah.
point.
Council
I'm
of Medical
living with
Research.
dying with dignity is entirely a different topic.
Okay,
It is
okay,
not.
Can I
Dr.
come
Bagai,
in?
allow Dr. Dhwani to just finish this. Dr. Bagai, 1 minute. Dr. Bagai, 1 minute. Allow me just 1 minute for Dr. Dhwani and Dr. Jailal to finish this off. A minute
Yeah,
to
just
both.
point of information, there's a 2018 document of the Indian Council of Medical Research which defines withholding and withdrawal and which recommends that the term passive euthanasia be abandoned altogether. It is not an appropriate way to characterize the act of withholding or withdrawal.
No, living with, I mean,
Dr.
dying with
Jailal.
dignity, for me, dying with dignity is something more different. The people are dying on the street. People are dying without treatment. People are dying in a condition where we are not able to help them. And there we should be concentrating more. And we should bring that there is a lot of people in the street and dying without any dignity. It is not that in the hospital. Here we are going to bring the monetary benefit, monetary things. There is no money is there, the people. So when there is no money, then will you allow the patient to die?
Absolutely
That is
not. Financial decisions should not play a role in deciding whether to withhold or withdraw
when we are
support.
talking that, we are using that when
Okay.
there it is bringing a financial
Absolutely.
problem. So let us not use such kind of things.
All right, allow me to get in Dr. Bagai. Dr. Bagai, you please go ahead.
Yeah, I think we've put in too many tangential points, and it's a little bit of I don't want any confusion in the viewer's mind. A lot of these ill-structured protocols have already and for a long time existed. What these guidelines have done is to streamline them to bring the patient family and the doctors on a common page for information sharing and understanding of critical situations. In India, end of life care is a very often forgotten chapter. I think no doctor will stop treatment on his or her own. But the important part of these guidelines is to give informed consent, is to bring the family to a level of basic medical understanding of explaining to them what brain dead means and what chronic vegetative state means. The ultimate decision is going to be of the patient's families. But the important point here is these guidelines have brought more objectivity. They have kept the emotion away from the rationale. They've kept logic and science upfront to remove the clutter. So these guidelines going forward in the long run are good. Implementation on the ground is not that difficult. To form a 3-member team in 2 levels is not difficult. It's not only dealing with ICU patients, which we are talking in terms of these guidelines. We can even encounter these events even in the general ward or in a double room or in a single room. Even patients who take their relatives home as leave against medical advice, it will also cover and protect the doctors. So what I differ with Dr. Jailal is on the point, this will in fact protect the doctors in the medical community, not take them to court. I again repeat, these guidelines will keep them away from the court, and it is only to bring the patient family and the medical professionals on a same page, same understanding for long-term benefit, not only of the patient care, but the patient's relatives.
Okay, Dr. Bagai, very quickly, I want to ask you one question. And I know this is not a question very at the heart of what we are discussing today, but this is a question that many viewers will have and often is important for them to come to a conclusive decision. And that is, how do you differentiate a brain dead person, which these draft lines talk about, to a person who's suffering with a terminally ill disease? Battling a terminally ill disease. These are two important phases, and I think we need to inform our viewers about this.
Yeah, is that for me?
That's right, Dr. Bagai.
Okay, so when you're talking in terms of a brain dead patient, it's a prolonged comatose state in which your basic reflex functions of your brain don't work, which does not sustain your cardiorespiratory system without assistance either of mechanical ventilation or intubation. Chronic vegetative state has a different definition. And when you talk of terminally ill or irrecoverable conditions, it's a separate definition. Without going into the medical definitions of each, the important point here is to inform the relatives what is going to be recoverable and not recoverable, what is the immediate impact and long-term impact, and to tell them through the course of onset duration progress of all the medical interventions which already have been done and tried and indeed unfortunately failed. Information sharing to make patient families a part of the decision-making cycle is what these guidelines will bring in the forefront.
Right. Dr. Jailal, you've been, I know Dr. Jailal as well as Rahul Pandit both are raising their hands. Dr. Jailal, to you, how do you look at what's been discussed in this show? Many actually saying, most of the panelists here saying that it's going to actually protect the doctors, and also it just means that there's no unilateral motivated decision from any one stakeholder, as it were. It's covered up with multiple doctor panels as well as the family members all needing to be on board at the same time.
But the ground reality is different. What this information sharing is a part of the any treatment, whether we are doing a normal surgery or any treatment, it's a routine. We do share the information. But here, withdrawing the life, who is going to take a decision? It is a surrogate decision is there. And who is this surrogate? And who is going to define that this surrogate will be able to take? We are living in a condition where a lot of marital and maternal problems we are facing. The husband side, somebody will come and say, it is fine. And next children, somebody who is from the UK, he is calling and saying that it is not possible. And now it is coming into a great dilemma. Who is going to take this surrogate decision? And when we are putting somebody surrogate, whether you are going to make in the Aadhaar card enabled, and lot of decision, a lot of problem, then we need to have a separate person entirely to look into these issues. So this is already happening. One, this is information sharing is possible. And with regard to the brain death patient, the problem comes two things. One is a brain death. We are saying don't do any surgery, anything, any treatment. Second one is the government is asking them to motivate them for organ donation. Now there is a dilemma comes in the Glasgow scale 3 or 4. The top level neurosurgical center will say we can still do surgery and 10% possibility of recovery. But he is in a rural area at Glasgow level 3. It is definitely there's no treatment is possible. No, nothing you are going to do. It is not going to help the patient. So whether some treatment is going to help is also depend upon the which center it is being done. We have seen hundreds of patients where we thought patient is not going to recover.
Rahul Pandit?
I don't
Rahul
agree
Pandit,
with
do you want to
this.
respond to
Brain
what
death
Dr. Jailal is
dead.
saying?
This law has.
I
Yes. Can I talk?
Yes, please.
Hello. Yeah. So brain death is dead. There is absolutely no doubt about that. The law has been established in 1994, the Transplantation of Human Organ Act, under which the brain death process has been defined. There is already a panel of 4 doctors who come and examine the patient and go in a stepwise manner to declare the patient brain dead, irreversible coma, loss of complete brainstem reflexes, and lack of breathing, which is apneic test. And these tests are repeated 2 times, at least at an interval of 6 hours or more. And at the end of the second test, the brain dead is declared. There has been not one single case anywhere documented in the world that if the brain death was done exactly in the way it has been described in the law and the textbook, then the person has got any chance of coming back. That's why brain dead is dead. It does not require this law. It does not come under the purview of the Supreme Court judgment, and neither has Supreme Court. Actually, Honorable Supreme Court has not even included brain dead into that. Brain dead absolutely does not require anything else. It's a law. It's a completely established law by itself. What we are talking is not passive euthanasia. Again, a very wrong term. Withdrawal of life-sustaining therapy in patients who are terminally ill with absolutely no conceivable chance of making a recovery, and death seems to be inevitable. I think so. We need to be very, very clear. All these terminologies can be intermingled, but medically we have to be very clear what we are talking about. Brain dead is completely different. Withdrawal of life-sustaining therapy is different, and euthanasia is completely different. I think passive euthanasia, we need to get rid of the terminology completely.
So, Dr. Dhwani Mehta, very quickly to you, I possibly can give you just about a minute before I go to 2 other panelists. Dr. Dhwani Mehta, as we look at it, somebody who are not specialists, somebody who are just understanding what's unfolding with specialists on a panel, there seems to be a concern around how even the doctors view this very differently. Even the term passive euthanasia that the government has also used, that even medical practitioners are using, and one part of them say that this is the wrong word to be using altogether.
Yeah, it's unfortunate, and you're absolutely right. There should be consensus amongst the medical profession about this, and which is why in early 2024, the two prominent medical associations, the Indian Society of Critical Care Medicine as well as the Indian Association of Palliative Care, which is an important aspect that we haven't yet talked about, issued a joint consensus statement on withholding and withdrawal of life support treatment. So that should be counted as the authoritative, as or at least as one of the representatives of authoritative medical opinion on this subject. And that should inspire confidence among the public. But you're right, as in what is published in an academic peer-reviewed journal needs to be translated better to the general public. And I think all of us need to work better on ensuring that this information is made available in a simple manner to the people who need to use it, including healthcare workers as well as patients and their caregivers.
Right, Dr. Ratish Sareen, how would you want the viewers to be approaching the draft guidelines? Because at the end of the day, these draft guidelines have been put out in public domain for responses, whether it be from people, from stakeholders, from doctors, from the medical fraternity, and even from, as we call the Aam Janta. How should they be looking at this draft guidelines? How should their approach to this be?
See, basically for the patients and for the citizen, this is a progressive sort of thing. But the important thing from the point of view of our medical profession and the hospitals is that we need to strengthen the process of communication with the patient. And as I already mentioned, in our country, where there is a lot of diversity in terms of literacy, we have to be very, very cautious that people, the patients, the attendants, while they are making the judgment, because the draft guideline also talks about the shared decision making. Now that's very important. Shared decision making is making the attendants, the family members, as well as the treating team coming together and taking a decision. Now, if at all there is a advanced medical directive which is there, that actually paves way very easily. But in absence, then we say this is a surrogate decision which has been taken by the relatives or the kin of the patient, along with the treating team of doctors. So it's going to be it's bit challenging initially, but I think the doctors, the medical fraternity that we have in the country, they are well versed, they have excellent communication skills, and they have been serving the nation since so many years. So I agree that there will be initially there will be
All
a
right.
bit more
Okay.
hiccup, but it will be a progressive one. It will be a good one.
Okay, my last question, and this is to Dr. Jailal as well as Dr. Bagai. This is my parting question. I'm giving you an open interpretation question. It's for you both to answer it because you both may also have different opinions on it. Dr. Jailal, the fact is, it's not the government of India that has gone ahead and made this draft guidelines out of nowhere. It's a directive by the Supreme Court. And the Supreme Court just last year asked the government all over again, why have these guidelines not been made? There are some states that have gone ahead and actually gone ahead and made them as part of their state subject and gone ahead and made these, these guidelines. There are some states that have done that. How do you look at this now that we have done this discussion?
Yeah, I mean, in principle, that putting a
Dr.
guideline.
Jailal first.
Yep. In principle, putting something in a order or putting something in a guidelines is always good. But making it as a law or putting it as a law which is compelling somebody to do like that is going to be a counterproductive, because it is definitely in a country like India, which is a highly diverse country, diverse situation, the medical healthcare availability is not equal, and it will be very, very practically difficult for us to implement that. But associations all coming together, or the learned colleagues coming together, putting the guidelines and how best that we will be able to go ahead is absolutely a welcome one. Absolutely, it is a possible one. But I will personally say ethics is more important than legal in these conditions like that, because autonomy, beneficence, maleficence, and justice has to be implemented. It is not only the rule of law or something which is in the black and white has to be there. The doctor-patient relation is supreme. That is something more than just a law.
Okay, Dr. Sanjeev Bagai, the same question to you.
Yeah, I think what we need to do is we need to look at the ground reality. We need to see how the individual cases manifest. I love the romance of medicine, but when it comes to critical situation, very often the reality is very different. You see hordes of relatives of different backgrounds, of different lineages, which rally together, and each one has an opinion, each one has an advice, and they all gather outside ICU and they want to know. Each one wants a second opinion. It creates a huge commotion and stress on the medical community. These guidelines will filter down and make the access of communication crystal clear. It will prevent medical legal complications. It will prevent people coming a month later, 2 months later, that you didn't tell me this and see what happened. It will prevent later on complications for the hospital administration too. Communication is always there and ethics is always there. In the end, I would like to say, doctors are not gods. We will do our best every time to do whatever is possible in the best interest of the patient. These guidelines bring the doctors and the relatives on a common platform to discuss the best needs of the patient, whatever be the criticality.
All right. I mean, you know, we are out of time, but the fact is, and I think all of our panelists will agree, we have not even discussed possibly two-thirds of this entire topic. There's so many more aspects to this, the long-term palliative care, whether it be the living wills that are so much more spoken about. We'll have another round of discourse very soon, but even as these draft guidelines are out, it's our attempt to bring you experts who will be able to break down the larger framework of how this is to be viewed. Dr. Jailal, Dr. Ratish Sareen, Dr. Rahul Pandit, Dr. Sanjeev Bagai, and Dr. Dhwani Mehta. Thank you very much for joining us with your opinions, with your perspectives, and with facts. And to our viewers, thank you very much for sticking on, watching this. And to the viewers for whom this may have been triggering, this is our effort to break down what's happening.